Welcome to the New America Foundation Summit on Nuclear Nonproliferation. As I've heard, that's all the traffic we fought on the way over here. Thank you very much for helicoptering in. We appreciate your extra effort to get here. That's why we're starting just a tad late to allow people to come. We've got a number of people we're still expecting, but I think we should get started. We did do a little bit of a review to see just how many reform events we are competing with. So if you've been to all of them, this is your 31st event on healthcare reform. There's only about 4,322 more events to go this week. But you're in luck. This is not your average healthcare reform event. This is the event that will tell you everything you need to know or you will get your money back. We are going to explore the less well-publicized parts of the bill. Some say that this was an insurance reform bill, but it's funny to know that the great majority of the bill is on delivery system reform. And if you just do a sheer page-by-page analysis, is one of those fun little things we can do here at the think tank. We actually counted the pages. And there are 10 titles of this bill. The first two are the coverage expansion. So the first title is on private expansion. The second title is on public expansion. That takes up about 374 pages of the 2,409 pages of the bill, about 25% of the bill on coverage expansion. Just a quarter. More than double is on delivery system reforms. So that's something that people seem surprised about as we go from place to place talking about the new health reform law. They're surprised to hear that. So it is a little daunting. We put together a little, I assume all of you have this little handout. It is far from comprehensive, but it does give you a quick reference guide to some of the sections in the bill on delivery system reform, so that we can all start to find our way around the bill. So people ask, why haven't we heard about the Center of Innovation or this new focus on primary care or some of these things? And it's because really the second you start talking about value-based care, people fall asleep. If you start talking about affordable insurance plans or no pre-existing condition exclusions, people are immediately interested. But if you start a conversation that says, hey, let me tell you about the Patient-Centered Outcomes Research Institute and the comparative effectiveness research we're about to do, you've pretty much lost a friend right there. So it's just not sexy, but it is so important. And so we have gathered three of the sexiest ladies we could find to talk about the national health reform effort that is really, up till now, barely considered. So we think that this is going to be a very different reform panel. And aren't you really excited about this now? So the first panel, and I will introduce each speaker in a moment, will give us a sense of why we need delivery system reform, the goals of delivery system reform, and how the legislation takes a step further down toward the road of all of those goals. Now, the second panel will drill down a little bit further into implementation issues, demonstrating how stakeholders like state governments, hospitals, clinics are not starting from scratch. But we are beginning with more of a broad overview, and we're going to begin with our very own Shannon Brownlee, who's a nationally known writer and the author of the book Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer. She's our senior research fellow in the Economic Growth Program here at the New America Foundation, and she's been so important and a frequent communicator about why delivery system reform is in this bill this time. Kavita Patel, at the end of the table here, is a medical doctor by training and most recently served as a senior aide to Valerie Jarrett, who of course is a senior advisor to President Barack Obama. Kavita was heavily involved in the health policy development for the administration, but immediately before that also served as the deputy staff director of the Help Committee on the Senate side during the key lead up to health reform legislative efforts. So we look forward to her insights on the goals behind the new reform law. And in the center here is Sabrina Corlett. She is the Director of Health Policy Programs at the National Partnership for Women and Families. Ms. Corlett leads the organization's efforts to promote access to quality, affordable health care. Now, before joining the National Partnership, Sabrina was a healthcare attorney with the firm Hogan and Hartson. We're not going to hold that against her. But she also served on the Help Committee. Sabrina has done a remarkable work, as a matter of fact, getting the message out about the importance of patient-centered care, and I believe she also has a handout today, right, that was out on the tables about that. So we will have Shannon Brownlee kick off our panel, and I expect all of you to be thinking about questions for this panel, because I have questions for them, but I know them and I can talk to them anytime. So I would really welcome you to be thinking about those, so we can have a very active Q&A session in about 30 minutes. Thank you.
Great.
You can come up here.
Thank you, Julie, and thank you all for coming out. Actually, coming into the district, I wonder if a lot of people decided not to come because of the street closings. So here we are. Healthcare reform actually happened, and I'm sure a lot of people in this room are pretty astonished by the passage of the bill, especially after death panels and debate over public option and town hall meetings where people brought guns, and a woman who stood up and said, don't let the federal government touch my Medicare, and a guy named Joe Lewis calling the President of the United States a liar on national television. So after all of that, we actually have healthcare reform legislation, and as Julie points out, most of the debate, the public debate, centered on coverage, yet what's in the legislation is only partially about coverage. It's mostly about delivery system reform. And so clearly, behind the scenes, many people in Washington, around the country, up on Capitol Hill, and in this room were well aware that we needed to fix another part of healthcare, which is the dysfunctional, disorganized, and wildly inflationary healthcare delivery system. So what I want to talk about today is some of the overarching problems of the delivery system to sort of set the framework for what the solutions are that are not only in the bill, but also that we're going to be talking about over the next few months and years. And what the legislation, and this sets the stage for what the legislation means on the ground for providers. But in order to talk honestly about healthcare, we have to kill healthcare zombies. Now, what is a healthcare zombie? It's a misperception or a bad idea that won't die. And one of the misperceptions that is having a very hard time dying is the idea that our high cost of healthcare is driven by high prices. So the price we pay per unit of service, every office visit, every day in the hospital, every drug, and we do pay high prices compared to other countries. But the high prices are not what are driving the steepness of that spending curve. And that when everybody talks about we need to bend the curve, what they're really talking about is slow the rate of increase in spending, which is outstripping the rest of the economy by multiple percentage points year after year after year. So price is not the only thing that's driving costs up, and bringing prices down is not going to solve that rate of increase problem. It is really, the rate of increase is largely a function of disorganization in the way the system works and the way we pay. So I want to lay out what that really means through the lens of geographic variation. And this comes from the Dartmouth work. And in the interest of disclosure, I'm an instructor at the Dartmouth Institute for Healthcare Policy and Clinical Practice, as well as my work here at New America. So I'm going to talk about it through that lens. How many people have heard of the Dartmouth Atlas? A lot. How many people have seen a Dartmouth Atlas map? Great. So for those who haven't, let me lay out what the central message is. And the central message is that when you look at what happens to similar patients in different parts of the country, they get different amounts of care and different kinds of care. So if you look at heart failure patients and you look at them in different hospitals, they get different amounts of care. Hugely different amounts of care. If you look at people with pneumonia, if you look at people in the last 6 months of life, if you look at anybody you look at, there is tremendous variation in how we care for patients in different parts of the country and in different hospitals. And it means people get more care. When people get more care, it means we spend more. So just to give you an idea of what that really means, we spend about 2.5 times more in places like Los Angeles and Miami and Boston than we do in Portland, Oregon, and Minneapolis. These are Medicare data, and they're a pretty good representation of what happens in the rest of the system, but we could use information about the rest of the system. So the key piece of information here is people who get more care are not necessarily getting better care. They are not having better outcomes. They're not living longer. They're not necessarily having a better quality of life. But all of us are spending more. So and to give you a real idea of what that means, if you're in your last 6 months of life and you're cared for in Alhambra Hospital or Alhambra, I don't know how you say it in Los Angeles, but it's in Los Angeles. It's not a very big hospital. If you spend your last 6 months of life being cared for by that hospital, you will spend 1/5 of your last 6 months, 30 days, in the hospital, and you will be visited 125 times by a physician. Now, if you're that same patient and you're at Duke University Hospital, just to choose a very high-profile hospital, you'll spend about 13 days in the hospital and you'll see about 25 physicians. That's a huge difference. And it's hard to imagine that Duke University is actually withholding care from patients. So the question of why this is happening sets the tone for the 4 main goals that we need to have for healthcare reform. And the first goal is we need to have more organized care. Now, what does that really mean? It means that what's going on right now is doctors and hospitals, in effect, are these little tiny fragmented entities that are acting more like they're still a cottage industry than a $2.4 trillion industry. So what we need to do is increase the organization. And some of you, I know a lot of you have heard of accountable care organizations. You've heard of the medical home. There's a shared savings program. Each of these is aimed at getting hospitals and physicians to be more organized. And we have these models out there that are more organized, that are more efficient, that are doing a better job. The Mayo Clinic is one of them. The president has certainly, in various speeches, has named a number of them, the Geisinger Clinic, Kaiser Permanente. But what are they really like on the inside? Well, one of the main things is there's a shift from acute care focus of the hospital to primary care. That's one of the things that makes them a little bit different. Another thing is their doctors are usually salaried. The doctors talk to each other a lot more when they're caring for an individual patient. They're better at following evidence. And they the system, the group of physicians and the hospital, actually look at what their physicians are doing and how their patients are doing. And they often already have medical records, electronic medical records. So in effect, we need to get everybody else to get with the program. And there are provisions in the legislation to do that. So goal number 2 is care needs to be a lot more patient-centered. Now, what does that really mean? It needs to fulfill the needs of patients and what patients really want. And one of the ways to do that is we need to inform patients a whole lot better about what the trade-offs are, especially when they're facing things that are elective, especially when they're facing elective surgeries. So we need to make a shift from something called informed consent to informed patient choice. And this is really quite an enormous idea because it changes the relationship between physician and patient. Goal number 3, we need a science of healthcare delivery. There's this gaping hole in medicine, and it's called evidence. And this is something, when I tell people this, they look at me like my hair is on fire. Because most people assume that what physicians are doing is based on evidence. It's based on sound science. And in fact, at most, it is about half the time. So this is kind of a dirty little secret of medicine. It's a little bit like the pilot of your plane coming out and saying, I know what only half the dials do up there in the cockpit, but I know I can fly this baby. So we need to start building that evidence base, and the legislation has the beginnings of that. For comparative effectiveness research, it's about $500 million a year starting in 2013 for something called comparative effectiveness research, which is comparing one treatment against another for a given condition. And this is, in fact, only a down payment on what we really need. We need to spend public money on figuring out what works and what doesn't and how you deliver it. How we need to build systems that can really deliver the best kind of care. And we're not funding that kind of research. The NIH is funded to the tune of $30 billion, but most of that is basic research. It doesn't involve patients, and we need the kind of research that involves patients. So that, in effect, we need a Vannevar Bush, if any of you know your science history, who persuaded the nation that we needed to invest in something called the National Science Foundation. We need to think of the science of healthcare delivery in the same kind of way. And finally, we need to rein in the growth and in the capacity and spending of the healthcare system in these hot spots around the country, these places that are spending more and doing more, these places like Los Angeles, Miami, Boston, and for those of you who've read The New Yorker, McAllen, Texas. A minority of regions in the country account for the steepness of that curve because they are spending more, and they're spending more faster than the rest of the country. So in effect, if we can start to control the spending in those areas and in those hospitals in those areas, we can start to bend that curve. And if we don't control the spending in those areas and in those hospitals, we won't bend the curve. We will bend it very, very slowly. Increasing the number of organized systems, the ACOs, getting more evidence into the system will bend the curve very, very slowly. So, and this is where the legislation is the weakest, or it's the least explicit, is controlling the spending and the growth and capacity in those areas. So that, in effect, leads me to the final, to my final remark, which is another healthcare zombie, which is the only way to control spending in this country is by rationing. Now, if by rationing what you mean is telling somebody who has arthritis that they cannot have a knee replacement because it's too expensive or they're too old, or if you mean by rationing we tell a cancer patient that they cannot have an expensive chemotherapy drug that will increase that has the potential to increase their life by several months, they can't have it because it's too expensive, we don't need rationing. We are $800 billion away from needing to ration care, because that's about the minimum that people estimate that we're wasting on unnecessary care because the system is so disorganized, because it's growing out of control in these areas, in these high-spending areas of the country. So I think that we can sort of dispense with the term rationing, at least for the time being, and focus on getting the system that really serves patients and does what we need it to do. So some of the people that you're going to be hearing from are going to expand on many of these ideas. You'll hear from Ed Murphy, who's the CEO of Carilion Clinic, which is one of the leading ACOs. It's on the way to becoming an accountable care organization. That's a lot easier said than done. We'll hear about patient-centered care. We're going to hear about how states are going to be involved in this kind of shifting of the delivery system, and what kinds of payment reforms are really needed to help give hospitals and physicians the kinds of incentives that they need to make that shift. Thank you very much. And I think, are we going to hold questions till the end?
Yes.
Great.
Yeah, I thought that's what we would do. So, Kavia, would you like to? Great. Come on.
Great, thank you. And I'm going to keep my comments brief because I have a feeling there are going to be a good chunk of questions. I'm going to talk a little bit about not just the legislation, but kind of the administration's thinking behind what was in healthcare reform, but also the work that started before healthcare reform passed and was even more formulated, which was in the American Recovery and Reinvestment Act. There was a pretty good chunk of healthcare changes, which were all meant to lay down some foundations, not even knowing what the future would be of any large healthcare bill, but even just acknowledging the need to update what the government had been doing at that point in time. So I just wanted to highlight that a lot of the investments in health IT, comparative effectiveness, which started a lot for the current comparative effectiveness model that's funded through health reform, really began in ARA, and that was a very explicit delivery systems reform effort. So when you think about delivery systems, I kind of approach it from, I always try and have a lot of sympathy for my colleagues who are providers, because it's more often than not the case that providers end up carrying the brunt of what needs to be done to bend the cost curve or to deliver better care, et cetera, and most often feel squeezed between kind of a rock and a hard place. The hard place being doing what they think is right for their patients, and the rock being the perceptions, and in a lot of times the reality of what the insurance industry, and what I would argue is already explicit rationing, because of what you can and can't do as a provider. So I'm giving you a little bit of a lens from kind of the clinician's point of view, and this is a pretty broad sweeping generalization of how both Congress and the administration looked at delivery systems reform, but there really was an attempt at making sure that this bill tried to improve the way we deliver care in the Medicaid, Medicare systems, as well as the Indian Health Service, the Public Health Service, and I would be remiss if I didn't point out the Veterans Administration, because the VA also is a large provider of care and has been a model that we've adapted a lot of our quality initiatives from within the federal government. So just to just build on some of what Shannon talked about, a lot of the pieces in the legislation don't specifically take place right away related to delivery systems reform, with the exception of a couple of areas. Payment updates, so there are geographic payment adjustments that get made on an annual basis. In healthcare reform, we elevated and created a more equitable flat fee upon which those reimbursement rates would generate. And just to give you a sense of kind of the magnitude of difference, we're talking about a couple of dollars that we're adding, but for Medicare providers or for providers who have per service, but for providers that have a good chunk of Medicare patients, this can amount to thousands of dollars per year. Very important, especially with any of you who know that most practices, especially if you're in the DC area, either do not take Medicare or Medicaid whatsoever, or you have providers that are just downsizing the proportion of Medicare and Medicaid patients. So you can imagine the conundrum when you expand access in a program and then simultaneously have a movement afoot with providers who won't take that insurance. So the kind of equitability of the rates is something that goes into effect right away. The payment reform, another piece that's going to take effect right away that also was started before health reform, has to do with some of the Medicaid and Medicare demonstration models around the medical home. The Medicaid ones specifically have funding and begin in 2011. The Medicare demos, the Secretary of Health and Human Services actually released and identified grants and monies available for that this past year. So the goal that everybody's looking towards is showing how we can take the concept of the medical home to that next level, and also encouraging Medicare and Medicaid, which is a critical piece of this. Again, going back, I keep beating this as a dead horse, but going back to the point that we're going to add millions to a Medicaid program, how can we really redesign models of care? Another piece, I should say that was two. A third piece that's important but doesn't have immediate effects but is getting stood up immediately, so to speak, is an office, I forget the formal title, an office for dual eligibles within the Office of the Secretary of Health and Human Services. And the reason I point that out is because those of you who are coming from states or thinking about states that might have high-risk pools or looking at populations that can be high cost, you're really talking about, in a lot of cases, you're talking about dual eligibles, people eligible both for Medicaid and Medicare, obviously. And as a result, there's quite a bit of interest from states, local municipalities, as well as the federal government to try to make that population get the best care but control these costs. So those are pieces that I think when people, especially you have to remember, I come from, all my friends are doctors. A good chunk of them are very nervous, very supportive of what happened, but are very nervous about this, because nobody, and this is not a knock against any particular group or legislators, et cetera, but nobody's really taken the time to explain to clinicians kind of how they can muster and navigate through this 2,800 pages that we passed. And that's certainly to be expected, and I think challenges for all of us sitting at this table are how can we take that 2,800 pages plus and make that a little bit more understandable. So hopefully today is the first of that series. But in addition to that, I wanted to just highlight some other pieces from the legislation that I think that Shannon didn't get to touch on that I think are huge. Julie mentioned the Center for Medicare and Medicaid Innovation, and the real excitement and the buzz around that is, thank God, finally, someone's actually going to do this. The $10 billion of funding that's attached to it in the legislation carries us from when it needs to start, which is 2011 to 2019. Some could argue that that's not enough money, but given how tight the federal budget is, having that dedicated pot of monies is going to be very exciting. The challenge, I will say, I'm trying to add a little pearl of where I think some of the problems might be in doing this well. The challenge is taking that from something that we do as a demo or a pilot and helping to translate that into broader heterogeneous markets. And I do think that if you are a CEO or if you're running a hospital, I know Ed can probably talk about this, how do you really sit down, look at the dollars that you have now, knowing that the current fee-for-service system is not going to change, and that in your system you probably are going to be rewarded for the next couple of years for adding surgical beds or acute beds and not necessarily for beefing up your relationship with primary care. How do you then think about a model of delivering care differently, knowing that theoretically by 2019, this wonderful innovation center will have come out with a very good, solid base of evidence and also, hopefully, changed our really perverse sick care system that we reimburse for. So that's one piece. I wanted to also touch on the public health and workforce investment. Something Shannon said made me trigger the thought about primary care. Is that even though we had a decent match, all the medical students go through a process to become residents, and it's like a date that no one can forget, even though I'm forgetting it. March 15th, I did it a long time ago. And so the rate of the match and the percentage of students that are going into primary care did quite well this year. But in general, that doesn't really tell us where these people end up working. So a student can be really interested in working in primary care and then watch their mentors and colleagues say, this is a disaster, which is often the perception. This is a disaster, you can't make money, and you might as well go on and try to subspecialize after doing X, Y, and Z. Go do a sports fellowship, for example. Those are all very common conversations. So in the legislation, there's not only specific dollars tied to investing in raising Medicare rates for primary care physicians, but also in the loan repayment and training aspect to make those professions more attractive. So everything from underserved areas all the way through to careers in primary care public health, which is, I think, again, going back to kind of not a sick care system, doing prevention, doing wellness, and actually how to counsel patients in wellness and making some of those choices that Shannon touched on. So those are very important pieces that often get overlooked, along with public health training grants for our local and community health centers to not only increase the numbers of community health centers and the resources, but also to update the surveillance, epidemiology, and data systems of these centers. So in talking about evidence-based care, if I, as a doctor, have 7.5 minutes to figure out what's going on with my patient, and then I run back to my room and frenetically type into my computer, and I'm looking for an answer, I need to have a decent data interface that can not only capture the information about my patient, and this is more than an electronic health record. This is actually tapping into data that currently exists in my local community about rates of gonorrhea, for example, or about incidence of H1N1 if I'm treating a pediatric patient and their mother is really concerned about that. So those things are pieces that, regardless of whether a system rewards you or not, have to be in place, and the government decided that this was an investment in an infrastructure. And I say that because this is what I would argue, and I don't think any administration official would question this, is the first piece of that foundation. There was no question that this was not going to be the total and comprehensive bill to end all bills, but that it was a start. The insurance pieces in it, I think, are a critical start, and as Julie mentioned, got the most attention. The issues around payment reform, innovation, the medical home, the workforce, long-term support services, and the CLASS Act, so access to long-term care. All of these things I think are kind of looming, in my mind, very exciting opportunities. I do think that it's fair to say that a lot of people are still wondering what it is and don't understand quite how to explain it, not only to their colleagues, but to each other and to themselves. And that's a challenge, I think, for everyone in the audience and for ourselves. And then I'll just close by saying that the issue of cost containment is a very challenging one, because the most common feedback we get whenever we talk about cost containment is not only the rationing, but also this sense of stifling something that's very American. So the concept of kind of having what you want and getting everything that you want is something deeply, and I say this as a first-generation person, something deeply American. There's something that if we have it, we want it, we get it. I will tell you, having both practiced medicine, received medicine, and currently dealing with a parent who has to get a lot of intensive medicine, it's not clear you even know what you want. It's not clear you can even get what you want. And I would tell you that most doctors who take care of you and want to give you everything that they feel is the best care would tell you that deep down they don't feel like they're equipped with the best tools or the support that they need. And that's not just, whether you're in Washington, D.C., L.A., McAllen, Texas, or in any other system. So how do we lift this kind of cloaked veil that we have on healthcare from all degrees? So a 360-degree kind of opacity that we have right now on the delivery of our healthcare. And I think that remains to be a concept that just in general in America we haven't really been able to. It's like one of those things where you think kind of what care you're getting. We clearly realize we don't know what kind of care we're getting, but at the same time, no one can articulate what it is they're supposed to get. And I think that's why there's such a threat when cost containment and rationing and all these terms come into play. But if you dive deep into the stories of people who are either very pleased with their care or very dissatisfied with their care, you'll find that there are some themes in common, and most of the time people can't quite write down or articulate exactly what they would have defined as the best care that they received in 1 to 2 to 2 to 2 points. So I do think that what's exciting in health reform is that this kind of a dialogue around how do we work together, learn from each other, and offer each other assistance in making our systems better is critical, and that I look forward to your questions. Thank you.
Thank you. Sabrina, can we hear from you?
Thank you so much, Julie. I might just start with just a few words about the National Partnership for Women and Families, because I'm not sure everyone here is familiar with us. And those of you who do know us may know us primarily through our work on work-family issues. And you may be wondering, why is the organization that got the Family and Medical Leave Act passed involved in healthcare? What are they doing in healthcare? And why, in particular, are we concerned about delivery system reform of all things? As a consumer advocacy organization, it's just not the most natural space for a lot of consumer groups to be in, which is, consumer groups have primarily been focused on access, justifiably so. But we've been involved in healthcare for quite some time, and in the late 90s actually led the Patients' Bill of Rights Coalition, trying to get the federal law enacted. And it was actually that work that led us into a much deeper dive on healthcare quality issues, what sort of policies were needed to better define quality, better measure quality, and improve it over time. And that work, in turn, has led us to explore healthcare payment and delivery system strategies that will take us to that higher quality care, better coordinated care, more comprehensive care that would meet the needs not just of the average patient, but ideally our most complex, vulnerable patients and those that are dealing with multiple chronic conditions. Because we think that if we can get the system right for those patients, we can get it right for everybody. So today, Julie asked me to come and talk to you about patient-centered care. And so I thought I'd talk a little bit about what patient-centered care actually means. And a few years ago, leading up to the national debate on healthcare reform, we set out to investigate just this question. We first started to speak to consumer advocates around the country, and so we asked them, so sort of a starting question, what does patient-centered care mean to you? And this past year, we retained Lake Research Partners to follow that research with focus groups and a national poll of individuals who are either dealing with a chronic condition or are caring for a family member dealing with a chronic condition. And we asked them the same question. And the answers of the advocates that we work with and the individuals dealing with chronic conditions themselves were strikingly similar. So what do we want? We want access, number one, and that means access during evening hours and weekends, times when when we're dealing with work and family schedules. We need those off out of work hours. We want providers who know us as a person, not just a collection of body parts. We want somebody who knows our medical history, our treatment preferences, our home situation, any cultural, socioeconomic, or language challenges that we might face. We want communication, not just among the providers that are treating us for a particular condition or set of conditions, but also with us as individuals, and where appropriate, with family members that are taking care of us. We want support so we can manage our condition after we leave the hospital or the doctor's office or other care setting. And we want help making informed decisions about our care that are in line with our own preferences and backgrounds. And we also like the idea of a team approach to care. That really resonated with folks in our focus groups, interestingly enough. A lot of times when I talk to groups, particularly among clinicians, there's this stereotype of the demanding patient, who wants to access to the top specialist at this academic health center. But, the groups that we conducted, people are really open to having, nurse practitioners, physician assistants, non-MD professionals manage and care for them, particularly those with chronic conditions. So during the healthcare reform debate that took place over the last 18 months, we used this research to both assess the kinds of delivery system and payment models that were being put forward, and also to lobby for specific provisions in the bills. We focused on 5 key things. So, number 1, does the new model or payment strategy allow for an understanding of patients' and caregivers' needs and preferences, such as through individualized care planning, geriatric assessments, or ongoing clinical monitoring, those kinds of things? Number 2, does it emphasize care coordination and care management, particularly for people with multiple chronic conditions? And number 3, does it focus on health outcomes and continuous quality improvement? Number 4, does it support patient and, where appropriate, family caregiver engagement and an improved experience of care? And number 5, does it promote accountability, not just through measurement and public reporting, which are critical, but also through transparency for any new financial incentives that could be influencing provider behavior? Our conclusion is that the new law lays a very strong foundation for improving the patient-centeredness of care. But looking forward, the devil's going to be in the details and how it's going to be implemented, and we're going to be making a big effort around the implementation of all these new proposals. We want to make sure that patients and consumers have a seat at the table, and to do so, we've recently launched the Campaign for Better Care, and there's a couple of handouts for you at the desk that outlines a little bit of what the campaign will be focused on. But funded by the Atlantic Philanthropies, we're joined in this campaign by 60 national consumer and patient groups, including AARP, AFL-CIO, Alzheimer's Association, and many others. We're focused on improving care coordination, continually assessing the quality of care that we're all getting and making improvements over time, and making sure that patients are actively engaged in managing their care and given the tools to do so. And we're going to be working at the state and national levels to build the consumer voice on delivery system reform, so that we're not only at the receiving end, but we're also at the table in the design, implementation, and evaluation of these new models and payment systems that are envisioned in the new law. These new payment models not only need to support the 5 patient-centered elements that I outlined earlier. Number 1, allowing for understanding of patients' needs and preferences. Number 2, emphasizing care coordination and management. Number 3, focusing on health outcomes and quality improvement. Number 4, patient engagement. And number 5, accountability. But they also need to be baked, those elements need to be baked into the monitoring, oversight, and evaluation of the models before they can be taken to scale. We also need to think about any unintended consequences as a result of changing providers' financial incentives. While bundled payments and gain-sharing models and ACOs may have great potential to align providers' interests and encourage them to work more closely together, it could also create competition and disputes. things like hospital readmissions penalties, bundled payments, ACOs could also create perverse incentives to reduce or avoid providing care to complex patients who might be less profitable under those payments. So consumer advocates going forward, we're going to be monitoring and tracking how these bundled payments for episodes are set. They need to reflect the full cost of care that beneficiaries need. And I'm not just talking about clinical care, but also other critical services like discharge planning, connecting people to community supports, medication reconciliation, language translation services for limited English proficient people. We also need to make sure that ACOs and other models are being held to robust quality standards. They're meeting quality targets, and those targets need to get more robust over time. We need to make sure there are adequate risk adjustment mechanisms in the payment so that payment is aligned with patients' health status. This will help mitigate against possible cherry picking of healthier patients. We need to make sure that race, ethnicity, language, and gender data are being collected, reported, and used to identify where health disparities exist and develop strategies to reduce those disparities. We need to make sure that patients know that there's transparency around what kinds of financial incentives providers are operating under. And in some cases, appeals mechanisms may be needed for patients who feel that those financial incentives are impacting the quality of their care or resulting in them being denied care that they think they need. And CMS needs to be monitoring the implementation of these models to make sure that providers are not purposefully avoiding high-risk patients. So we think the new law lays absolutely critical groundwork. We're very, very high on some of these new models and think they show great promise for not only changing the way care is paid for and delivered, but also actually paying for value, improving quality over time, and most importantly, getting us to better health outcomes, because that, at the end of the day, is where we need to be. But the next phase is going to be critical in determining whether or not those goals are realized. So thank you.
Thank you very much, and thanks very much to the panel for kicking this off for us. I think this definitely gets us started. While our staff are wandering down the aisle looking for people with questions, I'd like to start off with a workforce issue. You know, the AMA, a study came out that was not an AMA-based study, but published in the AMA Medical News today that really started to discuss the many the health professional workforce shortage issues that we're about to face in earnest. And then, of course, the AMA piled on by saying, they're already coming forward in 21 states and 17 medical specialty societies reporting doctor shortages. And I had my own brief experience with the healthcare system last week. Doesn't everybody? I mean, you get on these panels and you think you're going to talk about, and then next thing you know, you talk about last week how I had strep throat. And I went to the primary care physician who I know and love and was not working on Wednesday morning, and that's when I had strep throat. So I went to the CVS Minute Clinic instead. And this is going to start happening, with newly insured folks. And so it was an interesting little microcosm of how the system is about to work. Primary care physician not available either because of closed panel or because they're not working that day. And you go down to the CVS or the Target or the Walmart and you get your rapid strep test, which came back positive. And I walk down to the counter and I get my erythromycin and I'm done and I'm home and I'm reading these sheets, which are incredibly comprehensive. I learned more about my antibiotic than I'd ever known before, and I thought to myself, back when these retail clinics started popping up, physicians came out of the woodwork screaming and moaning and crying about how these were terrible, terrible things. And I remembered seeing something in the USA Today letter, and I found it again. So there was a physician who wrote an opinion piece in the USA Today, but in 2006 when these first started coming up. It's called "Medicine is Not Fast Food." And he said, without a hint of irony, this is what he said: the American public cannot have it both ways. They must decide what is more important, money and time or comprehensive, appropriate care. Right. So it's a really kind of neat quote about really everything that's wrong with our delivery system. So I wanted to put to the panel, how exactly are we going to be addressing these workforce shortages in the coming years? Ready, go.
I'll go ahead and start.
Thank you, Kavita. Yeah, you're the
Since
token
me
doctor.
sitting here
That's
not
right.
working in primary care is adding to the shortage as we speak. So which I know is something I'm reminded of often. So we had kind of this experiment in Massachusetts when Massachusetts passed its comprehensive laws known as Chapter 58 in 2006. It set forward, I think, a grand kind of experiment of sorts that a lot of people in national health reform policy making looked at. And the issue of workforce shortage continues still to this day in Massachusetts to be one that's very complicated for several reasons, not just because we added folks to, not just because we insured previously uninsured people, but there was also quite a significant public kind of awareness campaign about what health insurance should and could do for people who already had it, so prevention, wellness, et cetera. All the reports of up to 6 to 8 month wait times for primary care in certain parts of the state certainly are true. One of the controversies, and there's a decent study, although it's always hard to do studies with doctors, our response rates are low, no big shock there, but it's the controversy came when looking at what's the right number of physicians, and the Massachusetts area actually had what was felt to be perceived to be a high number of physicians than was necessary. So despite these comments about work at actual stories, this isn't lies and myths propagated by people, there were shortages in certain areas, wait times of months and months for basic primary care services, yet we faced literature and evidence showing that we actually had quite a few doctors on hand, if not a surplus of doctors. And Shannon's already mentioned some of the geographic variation in Boston, Massachusetts. So all of that showed us how flawed our delivery system was. And so taking that to the national example, one, it made us realize that the pipeline is never going to be, our pipe is not going to be big enough if all we're doing is looking at raw numbers with current data. And so therefore, kind of the reorganization of delivery, as well as what I think is not going to be written in legislation, but is going to be a battle that we'll see externally, which is this legislation of healthcare culture, this battle between healthcare cultures, physicians, nurse practitioners, physicians assistants, kind of providers, all feeling threatened by turf that might be lost or gained, is a very important conversation to have. We didn't have it in the legislation. That wasn't appropriate. But we need to also make physicians, and I settle on MDs and DOs because they're a great, huge number of the voices that were against minute clinics, for example, Julie. I would tell you that if we could reassure these MDs and DOs that there's plenty of work to go around and then some, then there would probably be less of a threat perceived about the jurisdiction and the turf, et cetera, et cetera.
Well, and I don't think my primary care physician is angry with me
no,
right now.
No,
I mean,
I
he
don't,
doesn't need to see my 1400
No.
strep throat.
But the
fact.
problem is that your primary care physician should know that you're on that you took erythromycin.
Well, and that was the problem. Is
and that you were
unless I
diagnosed
told
by
them, he's not going to know.
Culture, exactly.
It's going to be my little secret.
And so a minute clinic isn't going to work with your partner's practice plan.
But they could. I asked her. I asked her, can you transfer my records over to my primary? And she said, sure. Of course, I didn't have, the email or whatever it is I needed for her to do that, so she didn't. So it's still my little secret. But what seems to me what needs to happen is we need to connect those two together, right?
I'd like to challenge, and I think you were getting there, the idea that we have a doctor shortage. If you look at the Massachusetts experience, there are more doctors than you can shake a stick at in all of Massachusetts, especially in Boston. Even if you look at full-time equivalent, so the problem there is more a matter of disorganization than it is a real shortage.
Yeah,
perhaps. And so if we look across the country and we say how many doctors are used by organized systems, we have plenty of doctors. If we said if the entire country was organized the way, say, the Mayo Clinic is, we have plenty of doctors in the pipeline. But if we measure how many doctors we need on the basis of places like Los Angeles and Boston, we are just going to keep churning out more and more doctors. And that's a recipe for more and more disorganized care and costs going through the roof.
And I will say just one thing. There are surgical specialty and other specialty-based shortages. I do think that we have to tease out kind of where and what kind of shortages we're talking about, because there are as a matter of point, in the border area of Texas, for example, I mean, the number of neurosurgeons that can handle level 1 trauma is dwindling down to 2. And so I do think that there's a certain degree of highly specialized physicians for which, and then also for general surgery. So there are some shortage areas, but those are not areas that I think we're broadly talking about when we're discussing things like the question that Julie posed, and I would agree.
And people are all going into dermo because
cosmetic
we
derm,
definitely
not even
don't
just
need
right.
more
This
derm.
is, right.
I also think, and this is to some degree a state issue and not necessarily a federal one, but to really address issues relating to access and affordability, I think we need to look at making sure that clinicians are practicing to the full level of their license.
Right.
So, there is a lot that advanced practice nurses, nurse practitioners, other allied health professionals could and should be doing that they're just not. Either because their scope of practice is too limited in a given state, or because, there's physician supervision requirements or that kind of thing. So this is going to be a challenge for the states, no question, but, we need to start a conversation about it. And I'm not interested in getting into the middle of guild wars, but
that's clearly where we're headed. And I asked that lovely LPN that helped me out that day if she was able to prescribe, a whole bunch of, and she said, sure. I said, there are no limits on your prescription ability, and she said, no. And I said, narcotics? And she said, no. And I didn't get any. But I was really impressed by that. I didn't realize that there was so few limitations. Anyway, Allie, do we have questions from the audience? Are there folks that are ready and willing to ask our panelists?
Good afternoon, James Albino. I have a question. There's a little metric in HRSA called HIPSA and MUA. The numbers that make up that metric is used to distribute resources across a number of funding streams. The numbers that are used to create that metric haven't been updated since 1978. And I'm wondering if in the rollout of legislation and the planning of that legislation, did anybody look at that?
You're just making me, I thought we have something about the HIPSAs being updated in the legislation. I never say 100% until I have the text in front of me. I'm pretty confident that we actually have something in the legislation around that, because this has come up time and time again whenever we've tried to do any of our reauthorizations, including the children's health insurance. We've tried to add this on. So I actually especially know that this issue was important to a number of the senators on the Health Committee when I was working in Congress. And so if I'm not mistaken, I can circle back with Julie and get that information to the group. But I'm pretty certain we addressed some of that in there.
We also may be able to handle that on the second panel.
Yeah,
There's a couple of panelists that may be able to answer this on the second panel. Do we have any other questions in the meantime, sir? Allie, we have somebody up front. There are folks listening to us on a web stream, so if you just wait for the microphone for a second.
This one's for Kavita. I, too, have been in Washington long enough now to think that $1 billion a year is not a lot of money. But given the centers, I can't remember, but there were 10 or 12 things called out specifically in the bill, I think, for the center to look at. And how would you envision the center kind of setting priorities among those categories and kind of divvying up and just actually operationalizing this thing going forward?
So I do think that the center itself and its organization is going to be a huge, a closely watched issue by not only people like you and myself, but a number of payers in the country who are going to be looking at what they roll out. The intention, I know, in laying out some of those 12 areas, and it was everything from kind of your high-level acute chronic care disease all the way through readmissions and payment for specific services, including some of these never payments, so things we should not be paying for as well, which CMS has already started. The intention with laying out some of these titles and priority areas was actually a way of the Senate and the House to kind of send up a signal that if we don't do this on our own, kind of within the purview of this innovation center, then it's a preview of what Congress might need to do, especially as the trust funds are bankrupt and depleted, et cetera, et cetera. I think any CMS administrator coming in would need to closely look at that and then also closely align that with the ongoing demonstrations that are currently going. And then remember that part of that $10 billion is going to be to help replete resources, in the sense that for the longest time in the not just the previous administration, but for years, we've never really had a research arm of CMS. It's supposed to be research and demonstrations. So we've had these demonstrations with no funds to research those. So the priority will be to make sure that the first sets of projects and pilots are very heavy on, I think, the pieces that Sabrina touched on, so consumer and kind of the equity of who's sitting at the table, as well as the rigor with which you can translate any lessons learned from that, which has been missing. So hopefully the pilots coming through would be something that can be shown to other people to say, you can do this too. So the generalizability will be huge.
Will you all help me thank our first panel? Thank you very much, ladies. We're going to welcome up our second panel right now, and our moderator for panel number 2 is our very own Leif Hasse of our California program. He's the director of the entire California program at the New America Foundation, but more relevant for today is the fact that he's worked on a California task force on affordable care with Micah Weinberg, and they'll tell you a little bit about that work as we get started here. And Leif, I'll let you introduce your panelists unless you really want me to.
No.
Okay.
Sure. Well, thank you very much, Julie, and thank you all for coming today. I'd like to say I'm one of the few only representatives from California who's not here looking in one way or another for federal money, at least not officially. After health reform passed, Atul Gawande rightly pointed out that the much-feared federal takeover of health care actually depended, for it to work, on states, local communities, and clinicians, and that seems about right. We don't yet know whether the remarkably broad set of efforts to jumpstart payment and delivery reforms nationwide, embedded in some 50 pilots and 30 demonstration programs, will result in a nudge, a shove, or merely a ripple. But as the first panel showed in detail, the efforts to create more organized and coordinated efforts to deliver care with the aim of bringing down costs and creating more value for payers and patients are as critical to this law as the landmark expansions of insurance coverage. Indeed, delivering on the promise of expanded coverage will depend in large part on making real headway on the elusive goal of reining in health care costs, especially in a period of tight budgets and social needs that include and go beyond health services. Getting the maximum value for each dollar of health care spending is both an economic and a moral imperative. We're going to turn in this panel to look at specific on-the-ground efforts by healthcare stakeholders and governments, both to capitalize on the opportunities in federal reform and to adapt to its provisions. And our first speaker is Dr. Ed Murphy, President and CEO of the Carillion Clinic in Roanoke, Virginia. It's a health system that's over 100 years old, that owns or co-owns 9 hospitals with over 1,200 beds, runs a children's hospital, a heart treatment center, women's and mental health centers, primary care clinics, and is affiliated with the new medical school. Carillion, under Dr. Murphy's leadership, has been a national leader in coordinating care well before the incentives existed in the new law. Few hospital systems will be both as well positioned to adapt to the reforms or as keenly impacted by it. Secondly, states are already scrambling to make sense of reform. In the short run, figuring out how to create high-risk pools in concert with the federal government, mid-term designing insurance exchanges, and long run paying for an expanded Medicaid program and Medicaid population, among many other things. However, many states are not starting from scratch. Anne Gauthier of the National Academy for State Health Policy, one of the country's foremost experts on state-based reform, will focus on the opportunities that exist for states such as Minnesota that have been national leaders in creating new systems of delivery and payment. One of the biggest unanswered challenges both for public hospitals and for states is how the existing safety net system of coverage, which serves the uninsured and undocumented immigrants, among others, will fare in the wake of federal reform. Federal dollars which used to go to hospitals and states to care for the uninsured will be shifted to help underwrite the costs of insurance expansion and to pay for patients in new settings such as community clinics. And Claudine Schwartz, the Assistant Vice President of Policy at the National Association of Public Hospitals and Health Systems, we have the ideal guide to help us understand this shift. And finally, California has been historically the home to the kind of managed care organizations, integrated care systems such as Kaiser Permanente, and physician multi-specialty groups to which this law gives a big leg up. Ironically, this model of capitated and delegated care is eroding in the marketplace just as it once again gets its moment in the sun, as it were, nationally. My colleague Micah Weinberg, who with me has been leading a group of diverse, high-level stakeholders in California to explore ways to get better value for the state's medical spending, will end the panel and speak about how California can get its mojo back. So with that, Dr. Murphy.
Thank you for inviting me today, and I think I really appreciated everyone talking about how dismal the traffic was going to be, because I drove out here today, and as I do with some regularity, it was actually the easiest trip to downtown Washington I've ever done. I think everybody was adequately scared away. Either that or I was just luckier than I have any right to be. We've been undergoing a significant transition in how our healthcare system delivers care and organizes itself to deliver care to the community, and are very interested, and I think that the whole transition to accountable care is going to be an important one, or at least I hope it will be. But I think first a definition. One, when one talks about accountable care, I think one has to talk about what the accountabilities are, and I think there are three. I think one needs to be accountable for outcomes. Nothing new about that. Most doctors would agree that that's the case. Service. We're allegedly a service industry. It's hard to tell sometimes if you actually go to the doctor. But at least people would understand the notion that they're supposed to be responsible for service. And the final one, though, I think, which is very new and outside the tradition of medicine, is efficiency. It's important for us to understand that providing tests or rendering treatments or doing admissions to the hospital or providing surgical care that are costly, potentially dangerous, and that don't have any realistic chance of helping patients is every bit the mistake as a medication error, missing the diagnosis, or prescribing the wrong medication. I think that there's a lot of insight into that when you tell people about it, although it's kind of not where we live. And so it's going to require significant transition, and transitions are messy places. And this is a large transition by comparison to anything we've done in the past. And I'd like to spend just a couple of minutes talking about what I think the impediments are. And I've got them categorized into 5 impediments that I think stand in the way. And if these impediments didn't exist, then the results would already be in place. The first, and Shannon talked about this, and there's a benefit to going late, and when you go late, everything that's worth saying has already been said, and there's no exception here. The first is the payment system. We talk about, the sort of the tradition I grew up with doctors is everybody thinks about Marcus Welby, and you're there to care for patients. The reality is that's not true. We're driven by the payment system, and the payment system is organized around transactions. In healthcare, it's all about billing codes, and we get paid for doing stuff to you and not for taking care of you. A lot of things that we'd like to do, like the whole medical home movement and other things we could talk about later if there are questions about it, one of the impediments of going there is because the stuff that you would do don't fit well into billing codes. And if you can't fit it into a billing code, it's very difficult to justify doing it. We're paid for doing more, whether it's valuable or not. And the real perverse incentive is that we're penalized for savings. If we avoid doing something which is unnecessary, that's lost revenue to the system when expenses still remain. Very difficult to get out from under that trap. The other thing is that the payment system of transactions is well suited for acute and episodic care, which is the first half of the 20th century. The real public health imperative of the 21st century is complex chronic diseases, which is longitudinal care management. And episodic transactions do not lend themselves well to effective treatment of medical care of chronic conditions. The second is organizational structure. A good bit of advice that I received some time ago from somebody much more learned than I was that all systems are perfectly aligned to get the results that they get. And our healthcare delivery system today is perfectly aligned to get the results that we get. It's fragmented, it's episodic, and it's designed to maximize the payment system, which is designed around transactions. If we want to do something different, and this is where I think a lot of the healthcare economists make a mistake. Healthcare economists would argue that all we have to do is change the financial incentives, and then magically it'll be like pixie dust, and magically everybody will start doing stuff differently the next day. There's no evidence for that. As a matter of fact, there's evidence to the contrary. I would argue that the problem of the experiment of the movement to managed care in the 1990s was all about changing the financial system and the financial incentives without changing the delivery system to take advantage of the new incentives or deliver the stuff that was desired. Kavita mentioned the third one. I think inadvertently, but I wish he'd gone on. It would have saved me the trouble. It's the culture of medicine. It's intimately enveloped in the previous two things, but as doctors, we're all about autonomy and independence. Effective management of patients with chronic diseases is all about teamwork and consensus. Avoiding that which is unnecessary is all about teamwork and consensus. We hate that. Engineers will tell you that in engineering, fragmentation and variation are the enemies of quality and efficiency. It's every bit as true in medicine as it is in engineering, but we reject it because we're all about our independence, and we guard it jealously. It lends itself well to a sports metaphor. We're all about tennis, and well-practiced medicine is baseball. And not only are we all about tennis, as a parenthetical comment, too many of the doctors in the profession are John McEnroes. Fourth is that there's no burning platform. We're a profession that's highly resistant to change. The problem is that it's very credible for us still today to think that it's credible to maintain the status quo. And as long as we think that, doesn't matter if we're right or wrong, as long as we believe it, we'll act on that belief. And the evidence to support it is good. We have been trying to implement the sustainable growth rate formula in Medicare that would lead to an effect of that would to lead to the reduction in physician payments for services. This year, because they keep fixing it and rolling it over and fixing it and rolling it over and fixing it and rolling it over. Right now, we're looking down the barrel of a 21% reduction in physician fee services. Nobody believes it's going to happen, including me. It won't happen. They're going to fix it. If they didn't fix it, there'd be imperative for people to think about doing something different. Fixing it enables the status quo. And they'll fix it as sure as I'm standing here. And hoping people will gain insight into long-term incentives built 5 or 6 or 7 years into the bill, which I think is a very good bill and set us out on the right track, is difficult to get people to drive changes in how they deliver care day in and day out, because the history that they've lived with was every time they got up to the precipice of needing to make a change, the government always fixed it and made it okay to stay the way you are. And the final imperative is healthcare insurance company resistance. And let me first say that there's a lot of insurance companies out there. We work, and I work with many of them, and they're all over the map. Some, and I could name them and I won't, are highly compatible and sympathetic and consistent with trying to move in the direction we're trying to move in. The reason that I don't want to name them is because there are others who are highly resistant, and I couldn't name the former without naming the latter, and I would prefer not to do that. But the reason that you need health insurers to work with you to figure out how to practice medicine differently is that you need their data. You need, even if you've got a very effective, very high quality electronic medical record, which we do, we can only have data on stuff that happens within our confines. If patients go elsewhere, the insurance companies know about it because there's a bill attached to it, but we don't know about it. And you can't manage what you don't know. And the data have to be real time. Insurance companies guard those data. Well, first of all, they don't have real-time data. And so to be able to comply with your request for data requires them to do a lot of work, which is expensive, it's time diverting, it's attention diverting, and they don't want to do it. And I get that. I mean, I'm not it's not a value judgment, it's just a fact. It's not a priority for them. It's expensive, they don't have the expertise. The other thing is they don't want to let those data go because those data are proprietary. They consider release of those data in ways that other of their competitors can see them as a competitive threat to them. For example, if you and 5 other insurance companies are responding to a company's request for proposal to underwrite the health insurance, it's very useful for you to know what your competitors' experiences in providing claims to their other customers, and you can sort of make guesses about what their price, their cost structure is, and use that as a competitive advantage. The other thing, though, that I think is even more important than all of that is that movement of accountable care, which really puts the physician group and the healthcare delivery system, the provider system, in charge of the accountability for what happens to patients is a direct threat to the business model of insurance companies. Insurance companies have positioned themselves to be in the business of managing care. We're what stand between you, my customer business, and those bad providers over there who are always looking to pick your pockets. I stand in the middle and protect you. If the doctors and the healthcare providers are responsible for being efficient and managing the care and looking after your dollars, then the insurance company have been relegated to the position of largely financiers, which can be commoditized. And that's a direct threat to the business model of the insurance industry. So it's rational for them to be resistant. I think that we're not going to be successful, and let me, transitions are messy places. We're not going to be successful in achieving the goals that I think we could all agree to readily, at least those of us in this room, without addressing those fundamental impediments. And they're not for the faint of heart. So with that, thank you very much, and I think I lived within my time, and so I'll defer.
Thank you very much. Dan?
I have some slides that I'm hoping we can put up. Wonderful. And I'm going to guess that this handy-dandy controller is going to help me control them. So we'll see if that works. But anyhow, it's really a pleasure to be here today. When I was asked to speak on this panel and Leif and I connected, he asked me to talk about some of the state implementation obstacles and opportunities in the area of the delivery system challenge. And I said to him that I would talk about both of those, but I really wanted to focus on the opportunities. because I think at this stage the opportunities really abound, even though I make no pretense that it's going to be easy. So, and that's because there's an awful lot in this bill that presents opportunities, even though, as has already been said, it's a down payment only. And the second point is that there's an awful lot that's already going on around the country that will serve as potential models. Ha-ha, it worked. So while this is a discussion about federal health reform, it's important to remember that it is and is going to continue to be state governments that do a lot of the work in making the healthcare delivery system function. Last November, NASHB released a paper describing the many roles that states play in providing healthcare services. It is listed here. It's an impressive list, and each of the terms that is here actually has a number of sub-roles that are detailed in the paper. The point is there's not a single role on the list that will not be affected by health reform. And at the national level, I would say that there's no one person or organization is an expert on all the roles states play and how they're going to be affected. There's a lot of complexity and many interlocking pieces to consider. Those of us who are working with states are doing our best so that we coordinate our efforts, and will hopefully be assisting them as well as the nation, the federal government. So, this is an animated slide. And let's see what comes up first. So there are several. Let's look briefly at some of the challenges that states will face. On timing, federal health reform is both too fast and too slow. It's too fast because the amount of planning it's going to take to implement the deadlines in the reform bill. Already, implementation requires lead time for things like changing systems, updating regulations, even things that seem mundane but really hold things up, like getting contracts into place. It's too slow because already there's areas where states are now seeking federal guidance, and I know that there are many who are working hard to get that out at unprecedented speed. Federal agencies will be issuing various regulations and guidance as time goes on. But since pieces of the legislation phase in over time, there's a risk of dissatisfaction, and changes might happen along the way, who knows, that are going to make it hard to plan in advance. With respect to capacity, this has been mentioned today, and even the controversy around it, but I'm talking about provider and plan capacity. It's an issue. Will there be enough providers out there to provide the services when health reform is fully implemented? Will we have enough doctors? We've already discussed that today. We have too many in some areas, too few in others, and the distribution problems are perhaps even the greatest of all. Another issue concerns resources. Frankly, reform implementation right now at the state level is happening in the context of highly constrained state budgets, which, by the way, have to balance in almost every state. They've already have many states are struggling to keep up with the administrative demands of existing programs, and that leaves limited capacity to take on new challenges associated with national reform. It's really not just, and although it is, about paying for an expanded Medicaid program, but also many states have furloughs, hiring freezes, and shrinking staff, which makes it very hard to plan for, understand, and implement the new programs. And finally, leadership, which is probably the most important. I'll come back to that. This fall, we anticipate a substantial change in state leadership at the governor's level. There is likely at least half of the new states are going to be electing new governors. It's hard to know what impact this is going to have in individual cases. Some state priorities may shift more than others, but it's clear that there's at least, at a minimum, going to be a lot of education of new leaders that it's going to be needed. The good news here is that there are some new tools provided in the health reform legislation that can help, particularly over the long haul. And I think to be successful is going to require leadership to get started now and prioritize the opportunities that I'm going to turn to next, rather than let the challenges become overwhelming. Last year also, NASHB met with these state officials to learn about their priorities and goals, and we came away with 5 major themes here. And an important point to note is that states have actually been working to achieve these goals irrespective of health reform. The first is connecting people to services. That's obviously a cornerstone of this new health legislation and all of its coverage and insurance market reform and exchange provisions. With respect to promoting coordination and integration in the system, complex systems need to be coordinated. Many of the problems in the healthcare system today really trace their roots back to fragmentation and a lack of coordination, and I think Shannon laid that out for you very nicely. With respect to improving care for populations with complex needs, states are in a place where the focus of this happens, frankly. Medicaid serves people with disabilities and dual eligibles who have a number of needs. Coordinating all the services they need from multiple providers needs to happen by necessity at the community level, and states are in a position to support this. With respect to orienting the health system towards results, states are at the forefront of the movement to reorient the healthcare system by building ways to measure health system performance and reward results. They're working to develop metrics to more accurately assess quality and value, and they're seeking to use evidence to drive payment reforms. And finally, states need to get more for their money. Remember when we used to say cost containment, now we mostly say efficiency because we realize that cost containment per se isn't doable. However, we can, we think, slow the rate of increase, and we can ferret out a number of things that are wasteful and inefficient in the system. So overall, our system really is very high cost by international standards, and it varies within the country and within states. But there are significant opportunities to save resources by eliminating the provision of unnecessary or ineffective care, by reducing medical errors, by preventing illness and disease, and by reducing administrative costs. And I would support Shannon's call for a better organized system. In the overall structure of health reform, there are a number of new tools here, and I'm just going to focus on the latter 3, given the amount of time I have today. So let's just head at a glimpse at each of these 3 latter areas. With respect for patients with complex needs, they have multiple conditions. There are real opportunities for states to improve care coordination that would lead to healthier patients and potentially cost savings as well as redundant treatments are reduced. So the health reform legislation contains numerous opportunities here. We've heard already about the patient-centered medical home, and the bill has a number of places where this is strengthened, and there are opportunities for states. It's in a number of sections. I'm not going to list them for you here, but a couple of examples include they're specifically referenced in the CMS Innovation Center that was already mentioned. It's the first on the potential list of models to be tested. And eligible grant organizations include states as well as state-designated entities and tribal organizations. There is also funding for the patient-centered medical home in Medicaid and Medicare, some additional funding. There's a new Medicaid state plan option for a health home, i.e. a medical home here for beneficiaries with chronic conditions, and that begins in January of 2011. States can implement the health home programs, and they can get federal match at 90% for additional payments. There is also crossing into the workforce section, under the primary care extension program, there are hubs that are required to assist primary care physicians in implementing patient-centered medical homes. And the bill also makes available state support for state-based networks that can actually allow medical homes to begin operations for support with this support within a year. In North Carolina, for example, and it started first in the Medicaid program, but it is expanding to Medicare and potentially the commercial population as well. There's an extensive set of networks that provide resources to small practices. Remember that many of the physicians in this country country practice not in the organized care systems like Caroline or that others mentioned, but they are still in small practices. And a step to help them get better organized is to provide the kinds of support like educators, and care coordinators and social workers and others that their practice can't support alone but can be shared among practices. And there is opportunity in the bill for states to set up these kinds of networks. I will just mention for my second point here only one point that came up, which is that there is going to be a new office at CMS that is to improve care coordination for dual eligibles. And it has the chance, depending on how it's implemented, to align Medicare and Medicaid in terms of benefits, administration, oversight rules, which is huge, and to integrate service delivery and payment. This office is going to provide annual reports to Congress that include recommendations for legislative changes that will improve care coordination for dual eligibles. And once this office is up and running, it will be very critical for states to talk with them about their ideas for improving care. The legislation also contains various payment reform demonstrations with varying results, varying start and end dates, and undoubtedly varying guidance that is forthcoming still from federal agencies. We've heard some of the examples today. Some others are bundled payments for episode of care that include a hospitalization, global capitated payments to safety net hospitals that accountable care organizations for pediatricians to allow them to share in the cost savings, as well as Medicaid payment for certain emergency mental health services that are a high source of state costs. Not all of these will be successful, but since we don't know yet what works in this area, we're going to need to try them. Some may work better than others, some may work better in some areas, or for some populations than others. So my suggestion for states when I'm speaking to a state audience is to tell them to look at all of these carefully and think about those that allow the state to build on something that they've already done, which fit into the existing healthcare delivery system of the state and the way it's organized. Clearly, we've got the State Innovation Center, which is going to be a very important resource for states, and I'll come back to that actually in a moment. We have payment pilots that, in addition to those for primary patient-centered primary care, patient-centered medical homes for accountable care organizations, and I think I will not go into that, but I can cover that further in questions. There's also, the law establishes a new independent payment advisory board that not only makes recommendations to reduce the per capita growth in Medicare spending if it exceeds a target, but which also includes reporting on the cost and quality trends in Medicare and the private sector, as well as making recommendations regarding policies that can affect the private sector. State experience is going to be critical to inform the deliberations of the board, and my hope is that it will also, the board, will promote further state experimentation. The law sets up a process to add important quality measures to the Medicaid program, and some of these are an extension of the work under CHIP. Medicaid is obviously a much bigger program and is going to get even bigger still. And the legislation also adds quality measures for adults. One overt quality issue is that of hospital-acquired infections, and following on a similar program in Medicare, CMS is going to end all Medicaid reimbursement for treatment of those infections beginning only a year from now. A number of states have implemented such policies, about 12 of them, and looking to them for models is going to be useful. There are also some significant opportunities with regards to improving data collection, which I think has just come up, and data is really critical to improving the system and providing accountability, as has already been mentioned. It includes a clear federal plan to make performance information widely available. And an issue is going to be, there is likely to be system-wide reporting on quality and costs. An issue is going to be the degree to which this is done at the state level. While some states have developed really leading models, states do not generally wish to develop their own systems. However, in too many cases, our federal systems don't aggregate at the state level, which is really critical for state policy, and hopefully those lessons will be heeded this time. And I'm realizing that I have a lot to say, so I'm going to try to go through this part really quickly. There are a number of provisions to make some headway in the area of limiting administrative costs and that are going to involve states. The law requires an 85 or 80% medical loss ratio. That's the amount of money that is paid in medical care versus administrative costs. And states are going to have a process to review the increases in the health plan premium increases, and they're going to require the plans to justify those increases. It requires them to report on it and recommend whether certain plans should be eliminated or excluded from the exchange based upon unjustified premium increases. It's going to provide some grants to states to support their efforts to do this review. I will not go through the provisions, but we need to recognize, too, that as Kavita said, that not everything that states are doing happened in the health reform law, and that the stimulus bill provides a great deal of funding, as well as a number of activities are underway in states to promote health information technology adoption and exchange. It's important, though, that to coordinate the plans for HIT adoption and exchange with some of these other reform efforts. And I'm a little worried that that won't happen unless it's starting to happen at the federal level, but it's going to be very critical at the state level. I already mentioned the effort to coordinate Medicare and Medicaid with respect to the duals, but there's also an opportunity in the payment reform pilots. I think there's a great danger in terms of getting this wrong. So I guess the comment I'll make at this point is that in states where the same delivery systems care for Medicaid, Medicare, commercial, and Medicaid patients, as opposed to those who have pretty separate Medicaid systems, are the ones that really are going to be able to lead this effort. And I'm going to jump to, finally, because healthcare reform is so big, it's really a chance for states to engage in system-wide planning. Within states, there's really an incentive and an imperative, I'd say, to look beyond individual programs, agencies, or advocacy areas and look for the synergies. Right now, states need to make a series of governance decisions regarding who within state government will lead and coordinate the many efforts that are going to be needed to implement reform. We've heard in the last week about the appointment of a few czars already, and in other states the appointment is actually shared. This is old hat for a bunch of states, but it's new for many others. And I just will bring back here, I'm emphasizing the importance that we can get lost in the insurance market reforms, but and states have some critical decisions to make, but they really can be the laboratories of experimentation. I thought this week in particular it was good to bring a Supreme Court justice or justice's quote, and Justice Brandeis is well famous for his quote. So I will just briefly look at one courageous state. We already have some numerous lessons from Minnesota. We'll hear about California, and you've already heard Massachusetts mentioned today. Minnesota is working hard to transform its healthcare delivery system. In addition to establishing and funding a statewide health improvement program and doing some coverage enhancements for low-income people, it took a number of steps in a landmark legislation to it passed a law in 2008, and the law had a number of steps to collect and report data to achieve price and quality transparency, including the development of a standardized statewide set of quality of care measures across public and private payers, the collection and use of all payer encounter data and prices, public and private, and a transparent ranking of all providers in the state based on a combination of risk-adjusted cost and quality. It had several steps for care design and payment reform that are listed on this slide, experimenting with the baskets of care, think bundled payment concept, a statewide quality-based incentive payment system, and a standard of certification of healthcare homes with additional payments for patients with chronic conditions. So, to conclude, implementing healthcare reform is not going to be easy. Expanding coverage without quality and efficiency, though, is untenable. And while there are so many implementation challenges with respect to coverage, frankly, the principles are easy in relationship to delivery system reform. Here, we don't have the answers, but we have some pretty powerful directions, and this is the area, perhaps more than any other, where states not only have the power but the imperative to experiment. Clearly, implementation of federal health reform is largely a state responsibility in large part. And too much variation. States vary, their people, their resources, their needs, their delivery systems. Too much variation, particularly if you're talking about eligibility for coverage or if you're talking about whether you receive needed care based upon where you live. That's too much variation. But changing the delivery system can't be done without state actions, given their many roles, and importantly, because healthcare delivery is local. So Minnesota is an example of a courageous state, but there's much to learn from those that are taking smaller steps and from the obstacles they face. NASHP is working with states and health reform implementation in a number of projects, and we're planning a new web-based platform that will allow states to share their progress and ask questions and seek information on all aspects of health reform and collaborate with others who are also assisting states. We're aiming, though, not only to support state-to-state dialogue, but state-federal dialogue as well, and I think this is going to be extremely critical for the future. Thank you.
Thank you so much, Ann. I think we may all here want to be deputized not only as primary care physicians, but also as state legislative aides and others, given that panoply of things. Claudine.
Thank you, Leif. How is everyone out there? Wow, 4:30, talking about health reform implementation. I was thinking that maybe we could get Kavita Patel to, do an IV of coffee jolt for us all, because I know these are tough discussions. In any event, I would be remiss if I didn't give a special thanks to Julie Barnes at the New America Foundation. And just to pause for a second, Julie and her predecessor, Len Nichols, were just a tremendous force during health reform. And I think particularly for individuals like myself who work for a trade association and often have our very narrow interests in mind, they really challenge us to think outside of the box. So thank you for your leadership, Julie. Of course, these are exciting, but they are challenging times. And, when we think about the progress that we've made, coverage to 32 million Americans. I think that Monday after the Sunday health reform vote, we all called each other in the health reform community and said, did that really just happen? Did it happen? And those were delightful conversations to have. But unfortunately for my members at the National Association of Public Hospitals, many of them called with excitement. And then their next question was, so what's going on with economic recovery? Is that jobs bill coming? And, I really wanted to say to them, can you take a second and celebrate? But they really are facing some incredible challenges right now, as my colleague Ann mentioned at the state level. We have got tremendous uncertainty within the healthcare market right now, especially for safety net providers. 41 states overall have budget shortfalls this fiscal year. We at the National Association of Public Hospitals have been doing routine surveys of our members about what they're seeing since the start of the recession. We have seen a 10% increase in the cost of uninsured care at each of our facilities. That's on average. We've seen an average of a 23% increase in the number of patients served at our individual facilities. So we're really bursting at the seams, and as we really think forward to the challenge that begins now, which is rolling up our sleeves, getting to work, making sure we can prepare the delivery system for all these great changes, we have a lot of education and a lot of work to do, so that's why I'm really excited to join you today. Before I launch into the specifics of what Leif asked me to speak about today, which was, what were your concerns in the bill, and also what are some of the key challenges that you think about as you go forward with health reform implementation, I thought I would spend 2 minutes talking about who safety net health systems are and who the National Association of Public Hospitals and Health Systems is. NAPH serves the largest safety net and public hospital systems in the country. So when you think of us, think of the New York City Health and Hospitals Corporation and Bellevue, which served as a first responder during the World Trade Center attacks. And you can also think of Denver Health, which, in addition to the systems that were mentioned earlier, such as Geisinger and Mayo Clinic, is a highly integrated healthcare system in the western United States who's doing some incredible work to expand care in an efficient way. And then you can also think about where Dr. Patel trained, University of California, and some of the larger academic medical centers, such as Ohio State University, Louisiana State University, and those type of places. So oftentimes we get the question, public hospitals is great, you're doing wonderful work, but I don't go to a public hospital. And I really like to remind people that when they think about public hospitals, you have to remember that it's not just the work that we do to serve the uninsured and Medicaid patients. We're also first-line responders in terms of level 1 trauma care. For example, in the 10 major cities, we are the only level 1 trauma center. Burn care beds are dramatically decreasing, and we are now operating 59% of burn care beds. So when you think about your loved one getting in a car accident and you go to a level 1 trauma center, chances are if you're in San Francisco, you're going to go to San Francisco General, and that's a public hospital. So I'd just like to emphasize that to folks. The other, I think, kind of general misperception I like to bring up is that when folks think about a hospital, they think about their local community hospital. And safety net hospitals and public hospitals operate slightly different. And the reason why they do is they have had to be thinking for some time about how to stretch their dollars and capacity to serve the most uninsured that they can possibly serve. Keep in mind that for all these years that we have not had universal coverage or near universal coverage, safety net hospitals and community health centers have served as the de facto universal coverage. And so we've had to get really smart in terms of operating as integrated delivery systems. Right now, we serve, just the members of the National Association of Public Hospitals has 36 million non-emergency outpatient visits a year. That's 4 times the amount of a typical community hospital. Over 8 million of those are primary care visits. Many of the hospitals and health systems actually operate federally qualified health systems. Federally qualified health systems. So again, next time you're engaging in a conversation about the future of safety net hospitals and what happens for them post-reform, I urge you to think about it in the context of all of our needs rather than just the poor and the uninsured. As we entered healthcare reform 18 months ago, we really took on the charge from our board of directors to build on the strengths that we really, I think, have done such a great job at public hospitals throughout the country. And some of those themes have been brought up here today. They build on these concepts of coordination, collaboration, integration, and efficiency. And again, we've been doing those things because we've constantly been at the forefront of state budget cuts and expanding needs. So we've had to innovate to really expand services. We also had to recognize that federal funding is a very large piece of the way that we keep our doors open, and we'd be completely mistaken if we didn't stress that. Over 70% of the patients that are seen by safety net hospitals, the revenue that we get to serve them come from the federal government, the state government, or local governments. So oftentimes our CEOs joke, they say, there's very little in our control as an operating CEO to keep our financial state of our institutions strong in terms of the dollars coming in. Now they can maximize them in the way that you have at your facility, but it's very difficult to have general prediction in terms of what's to come. We also really wanted to make sure in the context of health reform, we offered ideas for improving quality and lowering costs. Very early at the beginning of health reform, it became clear that there was not going to be the energy to do comprehensive Medicaid reform. And that was a strategic decision that was made, and I'm sure it was a smart one. There was simply too many issues to deal with. And so many of those issues will be punted to a commission called MACPAC, which we look forward to participating with. Having said that, we did not want to leave behind Medicaid and all of the innovations that are slated for Medicare. And so one of the many things that we did in health reform was to advocate for attention to safety net health systems and to the Medicaid programs. So with those priorities in mind, we focused really on 3 areas of health reform. As anyone knows who works in the policy community and the advocacy community, you really have to keep your message crisp. So you can't come with a laundry list of 15 things. First and foremost, DISH was the priority, as Leif mentioned earlier. Disproportionate share hospital payments flow through the Medicaid and Medicare programs, and they are used to compensate for care to the uninsured as well as for shortfalls in federal payments. And that's a key point I really want to stress. You know, I know, Leif, in California, you had a debate around healthcare reform that predated our national debate, and we've had to do a lot of education around the issue that DISH payments, there's not a one-to-one correspondent in terms of a DISH payment dollar with a person who is uninsured. So, for example, if we achieve complete universal coverage, it may not be appropriate to completely redirect the DISH payments because we will have a lot of people on Medicaid, and unfortunately our state budgets are strained. So this is an issue that we continue to look out for and continue to look forward to talking with our commissioners at MACPAC about and Congress. We will see reductions in the level of Medicaid and Medicare DISH payments, and we're very happy to have worked with Congress to recognize that those reductions need to be pushed out in the latter years after coverage expands, and it is appropriate to take stock of where the reduction should take place, in which states, and where it is most appropriate to direct the dollars. This is particularly important on the Medicare DISH side of things, where Medicare DISH dollars now are not particularly well targeted. So the Secretary will be turning her attention to that as the reductions in Medicare DISH occur. The second key issue on our minds during health reform was this concept that we promoted and created called community-based collaborative care networks. We worked with our members throughout the country, and many of them, including some of the members that you mentioned, Ann, in North Carolina, said, you know, we really need to invest in primary care. That is the only way that we're going to be able to keep our safety net health system viable. And so they pushed and they pushed and they pushed us, and we came up with a proposal that basically allows for federal grants from the years 2011 to 2015. And the grants would encourage coordination of care between safety net providers, particularly federally qualified community health centers and safety net hospitals, so that there is better integration, meaning care managers, use of HIT, really looking forward to the expansion of Medicaid when we have 16 million new individuals in the program, and we need to know how to manage this care in an efficient way. We're very happy that was contained in the final bill, and we'll be working, like many people in town, toward appropriation of the appropriate resources very soon. The last issue that we really targeted was the expansion of fair pharmaceutical pricing to inpatient pharmaceuticals. It's called a 340B discount, and we'll continue to work toward that as it was not included in the final bill. Let me move now to some of the things that we have in our head as we now counsel our members on health reform implementation. Many of you right now are just trying to digest and keep track of the bill. So I urge you to, on the table outside, my colleagues have put together a couple of tools for you. One is a listing of the key safety net health system issues in the bill, and also a timeline of events that will take place in implementation. We have about 4 questions on our mind right now. The first one is, how do we handle the continued influx of patients from the recession? That's a short-term question, and that's an immediate one that, although it's not in the health reform bucket, it is certainly going to be weighing heavily in our mind. The second question that we have, and let me go back to the first actually, that question, I think, weighs even more heavily on us because we were very pleased to see an influx of resources to the community health centers in the health reform bill to the tune of about $11 billion. that's terrific. And as individuals who operate some of those community health centers, we in turn will benefit from that money. But we are also concerned that many individuals who will have been out of the system for some time will start accessing care at community health centers and will need specialty care. So we'll really have to monitor how that affects the influx of individuals at public hospitals. Secondly, we will have to make sure that we work together, and I know many folks in this room are working toward this already, for the extension of the enhanced FMAP, which is expiring at the end of the year. But states are doing their budgets right now, and they have to plan for the worst case scenario, which is they're not getting the money. So we are working together on that front. The second biggest question in our mind after we make it through this initial challenge is to really think, what do we do now to roll up our sleeves, get to work, and make sure the delivery system works for those 16 million patients who are coming in and will be enrolled in Medicaid. And that's not going to be easy. Right now, we don't have the capacity to serve those individuals. We need to do work around efficiency. The last question that we have on our mind is, how do we also handle the folks who will remain uninsured, which is 16 million individuals, 23 million individuals, at about a third of which are undocumented immigrants. This issue, of course, was not discussed in health reform for political reasons, and we really laud the success of Congress and the administration, but it is an issue that our members at the National Association of Public Hospitals have to address. So how we're tackling these questions is to think about, first and foremost, some of the innovative experiments that we have going on in safety net health systems. I'm delighted that we have been drawing from some of the examples at Virginia Commonwealth Health System, University Health System, which is right down the street from you, in Richmond, Virginia. They're doing some tremendous work to say, we need to get out there and contract with primary care physicians to manage the influx of patients in our emergency rooms. We're also looking at models such as Denver Health, where they employ the physicians, where they do school-based health, where they have community health centers. What can we learn from these integrated models? Second, we're working very hard right now to think about how we can collaborate with CMS. What can CMS be doing right now to create a glide path to coverage? There are many options on the table, including some of the waivers that have been entirely useful in the past and have even enabled Massachusetts health reform. We are also eyeing some of the longer-term opportunities via the health reform legislation. I mentioned our efforts to design and now fund the community-based collaborative care networks. We are also looking at opportunities to participate in the Innovation Center, accountable care organizations, which, again, we can't leave Medicaid behind on, payment bundling, medical homes. I mentioned MacPac already. This is going to be an area where we really need to roll up our sleeves and get to work about the issues about Medicaid payment rates. We are delighted to see that there was progress made in primary care Medicaid payments. It's long overdue, and we look forward to addressing some of the other deficiencies that are out there and working with our colleagues there. Additionally, we want to look at some of the other delivery system reforms that have payment implications, value-based purchasing, readmissions. And I will say we have many members who are ahead of the curve doing in the pilot projects already on value-based purchasing. What the question is on our mind now is, do we need to do anything with those pilot programs to make adjustments for health systems that serve populations that may not have the same opportunities as others in terms of access to care, language barriers, et cetera? I'm not suggesting that safety net health systems need differential treatment. In fact, our quality outcomes are as good, if not better, than the nation. But we do need to look at special populations. So with that, I'll close, and thank you so much.
Thank you very much, Claudine, and it's sobering that in this regard, there may be as many as 1 million undocumented immigrants who won't be covered in Southern California alone, even in the best case scenario of insurance reform. And with that, I call in Michael Weinberg, already here, for a bulletin from California.
Sure. So over the course of the past year, Leif and I have run something called the California Task Force on Affordable Care. This was a collaborative effort to develop strategies to get our state of California vastly better value for its medical spending. And this group, which will be issuing its recommendations within the month, involved folks who run hospitals, physician groups, consumer organizations, and insurers. Our assumption throughout was that federal health care reform was going to pass, as it did, which still seems somewhat miraculous to me, even a couple of weeks later, in more or less the form that it was proposed. And if it hadn't passed, the stakeholders asked us to get the band back together and figure out what we could do in the absence of federal health care reform. Let me tell you, that would have been a very, very difficult conversation to have, because particularly on the issue of value for medical spending, the states just don't have the levers that they need to create new, better functioning marketplaces for healthcare that promote the highest value care at the lowest possible cost for a bunch of different reasons that run the gamut from ERISA restrictions on states regulating the health plans of large insurers to difficulties in paying for public programs. Now, California has been a laboratory that Ann talked about for a lot of these models of high-value health care. But these models have been eroding in the last 10 years in particular. In this presentation, I'm going to give you a little bit of context about the state of California, and I'm also going to make the case to you that federal health care reform could, if properly implemented, help shore up the parts of the medical delivery system that work best in our state and around the nation. So a little bit about California. The first thing to understand is that there is no such thing as California. We have at least 6 distinct regional markets in California, and these markets vary not only between places like Fresno and LA, but literally on the neighborhood level in Los Angeles. So when you talk about a physician shortage or a physician oversupply in California, that is an entirely meaningless thing to talk about, because some neighborhoods in Los Angeles have plenty of physicians, some neighborhoods in Los Angeles have no physicians. So in a place like California, you need to think about these things in a much more fine-grained way. Now, California has been the homeland and the hotbed of a lot of innovation around integration of care. But one of the things that came out of this task force to remember is integrated care is not necessarily less expensive care. If the providers who are integrating in the way that we want can turn around and ask the market for as much money as they would like to have, right? So if you have a bundled payment or if you have a capitated payment, all of the sort of incentives within that particular bundle or that particular capitated payment may actually lead towards more integration and so on. But if the providers, through their market power, can say, and I would like that capitated payment to be twice as much as it was last year, then you might get a lot of good things around integration, but you're not necessarily going to get the cost-controlling effect that you want. And in California, even that level of integration has been eroding in recent years. So a lot of the things that we're talking about and have been very excited about in federal legislation, a lot of the folks who were on our task force said, listen, these are battles that we fought and lost 20 years ago here in California around the good parts of managed care and so on. And so that's important to keep in mind that in California, which is supposedly this model for the rest of the nation, a lot of the things that we're trying to do in federal health care reform have been eroding there. And one of the main reasons that they've been eroding is because providers have said, well, if there's no real market incentive for us to deliver better quality care at a lower cost, then why don't we just deliver as good quality care as we possibly can at a higher cost? And if we want to do that, how do we do that? Well, we buy a bunch of other doctors' associations. We buy a bunch of other hospitals. And so that's happened in California. And so when we look at the sort of prospects for controlling costs in a place like California, it's actually more difficult to do now than it would have been 10 or 20 years ago because of the consolidation of the provider marketplace. And then talking about the reason why this thing is difficult. So California is a mess. It is a mess. I work 2 blocks from the Capitol in Sacramento. We have a $20 billion budget deficit that nobody has any idea what we're going to do about, because we also have Republicans who are unwilling to raise taxes and for various different reasons have control over that, right? And we made a bunch of cuts last year that were then reversed by judges, and we're not allowed to make a lot of cuts because of the way that the federal health care legislation was written, but we also can't raise any revenue. And California is sort of a bigger, uglier example of this, but this is happening in all of the states. So this is a huge piece of context, and the federal government injections helped. So this $20 billion is after the additional billions of dollars we already got from the federal government. So those are sort of the things that people may not be worried about, that they probably should be worried about. On the other hand, there are certain things that people are worried about that they shouldn't be worried about, right? And that is that this is some sort of massive federal government takeover in which, you know, people are going to be marching into the states and setting up these systems in the way that they want them. If they were I'm not suggesting that they should do that, but if they were going to do that, that would be a lot easier than what we actually are going to do. And what we are going to do is we're going to leave this a lot up to the individual markets in these different states. And our board member and somebody who's been a really outspoken advocate on these issues at Atul Gawande says that, you know, the biggest concern about federal health care reform is precisely that it doesn't take over health care from the federal level, but it leaves a lot of this to the states. So, so what's going on in the states? Because I've given you guys a little doom and gloom, right? What's going on in the states that we should be happy about? And there actually is a lot of things. Like I said, I worked on this task force on affordable care. Honestly, this is what everybody wants to do who runs these sorts of organizations, but none of them have been sort of authorized by their boards or their spouses to run their organization into the ground and lose their jobs, right? However, there's a tremendous amount of goodwill that exists. There's a lot of everybody out there that we worked with in these physicians organizations and insurers and so on want to do the right thing. And so the great thing about this federal health care reform is that ideally it sets up better market incentives to allow them to provide the services that they want to provide. And one of the examples that I'm the most excited about in California is, you guys heard a lot about the 38 or whatever it was. That number was sort of imaginary, by the way. Rate increase for the individual market customers of Blue Cross in California, which was the reason that we passed federal health care reform, right? They might as well have sent those envelopes out with big red bows on them, right, and sent them to Obama, like, congratulations. Here's your momentum back, right? At the very same time, because in California, Blue Cross and Blue Shield are two totally different organizations. Blue Shield is a nonprofit insurer. Blue Cross is actually now Anthem Blue Cross, blah, 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 whatever. Point being that Blue Shield has a partnership with an independent physicians association, Hill Physicians, and with hospital system, Catholic Healthcare West, that has put together what they call sort of a virtual integrated delivery system for certain members of the public employees unions in California. And at the very same time that the premiums for the individual market customers of Blue Cross were going up by 38%, the state employees saw their premiums for this year actually go down in real terms because of that kind of virtual integration. But the reason why that was able to happen was because the state employees in California already have an insurance exchange. They already have what federal reform envisions is going to be accessible for a lot of other folks in the marketplace, which is to say that there has to be their standards for competition, their minimum benefit packages, there's transparency in terms of what the plans are doing, and so on. So what this indicates is that if you set up an exchange like this, that folks will change their business practices and coordinate in order to be able to provide high-quality medical services, because these are premier organizations in California at a more affordable cost. So there's some other things going on in California that I'd be happy to talk about a little bit more. There's a great bundled payment pilot going on. I wanted to quickly say, so we have a great sort of history of collaboration in California called the Integrated Healthcare Association. And California is one of the places where insurers actually have released a lot of their data to allow for quality comparisons and so on and so forth. I will say, not entirely parenthetically, that when these data are used for gauging the quality of individual physicians, they are the the physicians call into question whether or not these data are as valid as they could be, right? So that's a nice way of putting it. So that is, it's not sort of a, having the data out there is not something that everybody's going to be happy about, right? I mean, you cannot control healthcare costs without pointing out which folks are costing too much and which folks are inefficient. And there's far too many costs in a lot of cases, and there's far too much inefficiency in a lot of cases. So this isn't something that everybody is going to be in favor of. So the other piece of it, so that's kind of the private market piece. There's also the public market out in California. And as I mentioned, there's uncertainty with the state budget. And some of the other speakers have gone over some of the innovations in public programs. In California, we are doing, or we are attempting to do, comprehensive Medicaid reform through our hospital waiver process. And so everybody was getting together, everybody still is getting together from all the different stakeholder groups and attempting to move the state into more integrated care for these public program enrollees. Because right now, particularly with the highest cost patients, we have them in the least coordinated care systems. They're in these, Medicaid fee-for-service systems. So it's sort of ironic that the very low-cost people are often in the most coordinated, most efficient systems, and then the enormously high-cost people are in totally unintegrated systems. And that's a huge issue from the standpoint of state budgets. And so the state of California is attempting to move these public program enrollees into more integrated care. That would have been nigh on impossible without the passage of federal health care reform. And so the punchline is, I don't know, at least in what I'm thinking about it this week, is that to the extent that federal health care reform creates a marketplace that rewards value, it will build on the best parts of the California delivery system and does so just as these things are eroding and potentially in time to preserve them. So I think a little bit about, do you folks remember what Ben Franklin said when he was asked as he came out of the Constitutional Hall about, what did you just do in there? What did you create? And what Ben said was, it's a republic, if you can keep it, right? And I think that if somebody were to ask me, what did we just do, right? Which actually is what everybody is always asking me. What I would say to them is, we have created a uniquely American medical delivery system if you can build it. And there are a lot of aspects of federal health care reform that create a structure in which you could see how we would move towards a high-value system. But that structure is not going to structure itself. It is going to require the very hard work of everybody in this room and all the folks out in the states that have all the challenges that my fellow speakers talked about. And it's something that I personally am very excited about. So thank you very much for your time and for staying until now.
Thank you very much, Mike, and I remember Ben Franklin saying that personally. We've moved into overtime here, but the diehards remain, and I hope we have maybe 5 minutes for question. I wanted to ask, in light of this whole conversation, I wanted to ask Ed Murphy one question, which was, how did you decide, given the incentives that you talked about, given the impediments, how did you decide to position your health system as one that was going to specialize in coordinated care, in some ways bucking the current before the current reforms?
I ran out of medication. No.
There we go.
Yeah, there are those who would argue that it is a treatment-responsive condition. I disagree. Yeah, I don't want to be cavalier about it, but it's clearly right. It seems to me that if you go to medical school and what you're really, somehow you go into medical school idealistic. And when you emerge, too many of our colleagues wind up being sort of small business entrepreneurs in which the trade that they run their business is their services in medicine. And that's just not right. And how it's difficult to go to work every day and understand how complicit the system is. And each of us make up that system, so you can't blame the system without taking personal responsibility. Shannon made the point that $800 billion gets wasted in the system. Clearly that's true. To give you a sense, I mean, that's a huge number. How do you get your head around that? $700 billion a year, and when we first started talking about the 30%, it used to be $700 billion, and then we sort of wasted an extra $1 billion as things escalated. $700 billion a year is all of the money that the United States spent buying foreign oil from all sources back when oil was at its peak price at over $100 a barrel. And, oh, foreign oil is terrible. We can't afford that. Every day we waste that. You know, we waste that with this. The most expensive piece of medical equipment in the country. It's a pen in a doctor's hand. We're all complicit in doing that. And at the same time, we can't afford it. You know, we are running the risk of injuring our patients. We're not getting them the care that they need. And you just can't have it. You know, it's important. We've got an absolute obligation to our patients and our communities to to provide them with good advice, to spend their money wisely, to provide good care, and to do so in a sustainable way. And you know, after a while, it just becomes necessary to move in that direction.
Thank you very much. Time for a couple of questions here in the front row, and the microphone will get to you.
Brownstein, retired journalist. I'm very worried about November. I'm very worried about 2012 and all of these efforts to overturn what has just been achieved. Are you as worried as I am? And if not, why not?
Well, I would just offer that we do have some experience with nullification in the United States, and that effort didn't turn out too well. But
yeah, I would say in addition to that, sort of, there is not a long. So I'm a political scientist. I guess I should come out of the closet about that. There is not a long history of parties running successfully on repealing entitlements. And I predict that we're going to hear a lot less about this as soon as the Republican primaries are over. And then one small technical issue is that as it relates to the individual mandate, it's a valid constitutional question as to whether that's constitutional. You can kind of make an argument on either side. But you can't actually sue until the thing happens. And that means that the court cases related to that can't actually be decided until the individual mandate goes into effect in 2014. And it's sort of sneaky the way that they set this up, right? Because otherwise, until then, the cases won't have standing. Yeah.
I'm not a political scientist, but I did go on a site visit to the capital of Virginia, my home state, I might add, just a couple days after the first lawsuit was filed, and met with the Secretary of Health, the new secretary, because we had a governor change this January in Virginia, and we talked about it a small amount, but what he said was, the law is still the law, and Virginia is going to be implementing the federal health reform law while we are pursuing at the same time, our Attorney General is pursuing this lawsuit. And so couple that with everything that Micah just said, there's an awful lot that's going to be underway and going to happen before anything could even be undone. And the states even that have joined in are all moving actually quite actively to implementing.
One more final one in the back, or two more in the back, and we'll call it an afternoon.
Yes, I just wanted to give Ann Gauthier an opportunity to follow up on one of the 5 themes that she didn't get to talk about, which is one that almost everybody else talked about, which is promoting coordination and integration. And just, I work for a state government, and I'm having trouble seeing a lot of opportunities in the health reform legislation to really build on what's happening at the state level on coordination integration. And given what everybody else at the panel has been saying about this being such a crucial part of health reform delivery, I was wondering if you could just kind of point to some things that might make you optimistic that there are things that the states could really latch onto and to help accelerate their own efforts.
Sure, I'll just take a minute. I think that the patient-centered medical home, which is primarily focused on the outpatient side, is a very good beginning, and there are a number of provisions in the law that allow all states to move actively into that area. Those that are going to move into that area that haven't been thinking about it already will look to others that are taking the next step and trying to integrate hospital care so that they can do such things as align payment incentives so that hospitals don't get extra payment for unnecessary readmissions, but have an incentive to join with outpatient providers and to build systems that keep people out of the hospital once they've been successfully discharged. So there are a number of models now that really, and that they've got labels, and the labels mean different things in different places, but that's in terms of the actual delivery system coordination. I think there really is some opportunity. With respect to coordinating programs, I don't know how Medicare and Medicaid coordination is going to play out. That's something that has been plaguing those at the state level, feds, and those in the delivery system for years. But I think the fact that there is explicit attention and some funding to tackle that problem gives me some modicum of optimism at this point.
Final question, 20 words or less.
Okay, start counting. So I'm Renee Marcus Hoden. I'm from Community Catalyst in Boston. And I just wanted to follow up on the last speaker's comment about the erosion of integrated care in California. And if you could speak a little bit, or other panelists could speak a little bit, to any lessons from that erosion that could be applied now before we start these programs to prevent erosion in these programs that are, have so much hope and promise right now.
Yeah, sure, absolutely. I think one of the lessons in California is that you've got to get the regulatory structure right. And one of the challenges we have in California, without getting too much into the details, is that we regulate insurance companies in two different ways. One that has an enormously high standard, and that's applied to the managed care programs, and one that has much lower standards, and that's applied to the programs that don't manage people's care. And for me, the lesson that I take away from that is you can run all these pilots and you can do all these programs and you can have the government do great research on it, right? But if we don't actually set up the field of play in a way that is even-handed among different ways of delivering care, then you're going to end up undermining that so much more than you attempt to build it up through pilots. And I think that's a fundamental duty of governments, are to make sure that we get these sets of regulations correct. And that's going to be a huge, huge, huge challenge when some of these regulations, the high-risk pools are supposed to go into effect in June, right?
60 days. 60
days from now or something like that. So, I think that the takeaway is that the regulatory process here is just so critical.
I think last word for Claudia.
Sure, and I think it's really important to note that when we think about integrated delivery models or integration generally in care, one size doesn't necessarily fit all. We certainly learned that at my organization. We attempted to craft a grant-based program called the Community-Based Collaborative Care Network. And we found, the model that works in healthy San Francisco doesn't necessarily work in terms of the models in Boston. There's also other models in Florida with provider service networks. So we know that to be the case, and it's certainly true in terms of the private versus public sector. It may be worthwhile to note that I know the Government Accountability Office is looking into integrated delivery systems as we speak, and we'll be soon issuing a study on this. And I think feels the same way I do in terms of really looking at the regional characteristics and the strengths and drawing on those before you actually define a working model.
On behalf of the New America Foundation, I want to thank you all for coming and thank the panelists for both panels for their terrific insights. Exciting and daunting, and most importantly, to be continued. Thank you.